So when you do that math and you add all that up, you think, there's nothing else funny going on here. This is just simply a case of somebody who stopped breathing. Clinical correlation makes perfect sense. What do we need to do for her?
Breathe for her.
Breathe.
Ventilator.
Make her breathe any way you want. You can put a tube down her throat and breathe for her. You can rub her on the chest really hard so she wakes up and screams at you. You can give her a dose of Narcan. It doesn't matter. But you just need to breathe for her, and all that stuff will get fixed. All right, slightly different case. You're over in peds. 12-year-old girl comes in with a broken arm, and she's playing it up. There's all kinds of problems. You walk into the room later, and she's laying on the ground, flopping, flying around. She's all twisted up and contorted and stuff. And you're thinking, my God, what's going on with this woman? Somebody goes in and gets the blood gas on her, and this is what it looks like.
Trauma.
So let's walk through our same steps here. What's her EMEA? What's her pH doing?
Alkaline.
Excellent. So she's got an alkalemia. I can't write. What's her primary problem? This is oxygen.
She's hyperventilating.
CO2. Yeah, exactly. She's blown her CO2 down. Her CO2 has gone way down. So she's got a respiratory alkalosis. Is she compensating for it yet?
No. Not yet.
Not yet, because it's happened so quickly. This is pure respiratory alkalosis.
When
What
she passes
happens?
out, she'll compensate.
Yeah, exactly. It
She'll
makes
breathe
your
normally
pH go
again.
low. Stuff starts dysfunctioning. Actually, it turns out with the pH goes high, I'm sorry. Turns out with a higher pH, you bind all your calcium to your proteins, you get low calcium in your body, and that's what causes all those spasms and stuff. And you see people who come in and they're hyperventilating, they're twisted up and contorted
Well,
like
I'm
that.
all numb, I can't feel my finger.
Yeah. So how are we going to treat her?
Normal.
She's just the opposite of this overdose we saw a minute ago, right? Yeah, she's got to slow it down. Now, we can either sweet talk her and tell her to slow down. We can give her a dose of heroin and make her slow down.
Make her
Or-
bag.
Yeah, make her breathe into a bag. And that way, all that CO2 that she blows out is going to come right back into her again, right? So it'll help drive her CO2 back up, and her pH will come back to normal. Morning. All right. These look like they're getting more complicated, but I want to walk through 2 or 3 of these because they really show that it's not that hard to do. You guys all know the Pickwickian syndrome, the old blue bloater guys, the old bad COPDers. So you got one of these guys that comes in, and he's having a classic COPD exacerbation. Somebody gets a gas on him, and these are his numbers. He looks like this. He's your classic old Pickwickian guy. What's going on with his numbers here? He's
Not
Well, pH is kind of in the normal range.
Yeah,
Yeah, it is.
it's really not that bad. I mean, I guess technically you could say he's got a weak acidemia. May live there, yeah, exactly. Right, yeah, let's do the math and figure it out here. He's a little bit acidotic. So is his primary problem going to be a respiratory
Yes.
acidosis? Yeah, probably. That's a pretty big one. It's going the right direction. His bicarb, he's got a metabolic alkalosis, so that can't be the primary one. So his primary deal is going to be a respiratory acidosis. Now, how about the compensation? There's 2 ways you can look at this. One is you can say, he's compensated enough that he's pulled his pH all the way back to normal. He's probably pretty well compensated. Or you could actually crank out that math, and you could say, remember your CO2 should be 1.5 times your bicarb plus 8, roughly. And you can Google that up, or you can find it off of here. So if we crank this guy's numbers, I can't do 39.7. Let's do 40. 1.5 times 40 is 60 plus 8. 68, that's plenty close enough to 70. So you can say this guy's totally balanced. This is where he lives. He may be huffing and puffing a little bit, but this isn't the true COPD exacerbation that's giving him problems. He's just living there. And that's exactly what Louis Leos would want to hear you say. Is a chronic respiratory acidosis with the appropriate metabolic compensation. We got a couple more minutes?
Yeah, you're good.
Oh, excellent.
Yeah.
Okay. Another similar case. Older female comes in. She's got nausea and vomiting for the last couple of days. Turns out she started a diuretic. She's taking Diamox because she wants to lose a bunch of weight because her daughter's getting married next week and she thinks she can shed about 10 pounds of water weight. She's going to be great. And now she comes in all pukey and nasty and icky feeling and wants to know what's going on with her. Then we draw a blood gas on her. So what do we think about this one?
Alkaline.
Okay. Step one, she's got an alkalemia. So step two, what's her primary disorder? It's going to have to be some sort of alkalosis, right? So we crank through her numbers and say,
Yeah,
CO2. Okay.
bicarb is.
Right, the bicarb is definitely an alkalosis, so that's probably it. CO2 is an acidosis. That couldn't be the primary one, right? So her primary deal is going to be a metabolic alkalosis. And you think, now why would she have a metabolic alkalosis? Oh yeah, she's on Diamox. We know that causes a metabolic alkalosis. So clinical correlation fits, makes sense. Now, is she compensated enough? Well, A, you can already get a clue by saying her pH isn't very close back to normal, so it's probably not compensated enough. But let's crank the math on this to see what's happening here. We know that by the same formulas earlier, her, let's see, CO2 should be 1.5 times the bicarb.
72.
What was her bicarb?
48.
48 plus 8. So that's going to be 72 plus 8. Her bicarb should be, her CO2 should be 80. So she's not compensated. So now I've got to go back and look at her and figure out why isn't she compensated. Now, what her body would want to do is slow down her breathing so that she's going to build up more CO2. How much do you think you got to slow down your breathing to get your CO2 all the way up to 80 acutely?
Yeah.
Yeah, I'd have to hold my breath for 10 minutes to get my CO2 up to 80. So the reason she's not compensated is because she can't hold her breath that much. She'll get hypoxic. So because she can't compensate that quick, her pH is going up. Her pH is out of whack, and none of her receptors are working. She's feeling lousy. She's throwing up. It's all the nausea and vomiting. So clinical correlation stuff, that would make sense.
How do you fix it?
Take her off the Diamox.
Give her fluid. Yeah, hydrate her.
Yes, you can hydrate her real good. Sometimes in cases like this, you'll actually give them a weak acid solution. They use like a very weak acetic acid solution or something in IV fluid that'll just gently bring their pH up just a little bit. Turns out normal saline is actually even a little bit acidic. You know, you hear people talking about this hyperchloremic metabolic acidosis when they get chloride loaded. That's just tons of chloride that's in normal saline. So a couple liters of normal saline might actually fix it. All right. Two more quick ones here that might show why this becomes really important for you guys. Because your job, you got a lot of jobs, but the most important one I see is you keep my interns from killing people. Senior residents can get there, and I can't thank you enough for that. So we've got a patient, they're in resus 4, they came in with acute respiratory distress. They started to calm down, they're looking a little bit better. We've got ICU, it's come down to see them. It's perhaps a slightly challenged interaction with the ICU, and they eventually drop a consult that says, she does not need the unit, you can go to the floor. Contact the hospitalist, you can be seen in 19 hours after sitting in EIA. We're sitting there going, huh. I don't know about this. Let's take a look at this. So let's run through these numbers here. She actually does look okay right now. She was panicky. She was scared to death. She was grabbing people's lapels and hollering and screaming when she came in. Now she's calmed down a little bit. We gave her some Ativan. She's doing better. And the unit says, she does not look so bad. Send her to EIA. What's her step one. What's her emia right now?
Acidemia.
She's definitely got an acidemia. So what's her primary disorder?
Respiratory.
Yeah, respiratory.
Yeah,
I
she's
call
got
it not too bad.
Some
Yeah, actually, CO2 isn't all that bad either, is it really? She's got a little bit of a respiratory acidosis. She's got a little bit of a metabolic acidosis, but not much.
She's only 68 for PaO2, like 60%.
Yeah, her O2 is low. That's alarming for sure. Let me put that on hold for a second. But let's crank through the numbers with this. If her
You give her bicarb?
her CO2 should be 1.5 times her bicarb, right? Bicarb's 20. So that should be 30 plus 8. So her CO2 should be 38. But she's got a CO2 of 45. Huh. Make sure we did that right. CO2, yes, CO2 should be 38. Keep going. What's going on here? You should have a CO2 of 45. I get it. I know what's going on with this gal now. What's happening with her? Why is her CO2 higher than it should be? How do you get a higher CO2 than normal?
You retain.
You stop breathing, right? So we gave this anxious, panicky gal a bunch of Ativan. She's calmed down. She looks better. We're making this clinical judgment of, you don't look so anxious. You don't need to go to the unit. But when we crank through this math, she's not compensating like she should be. She's letting her CO2 rise. She's not breathing very deep. This is the classic picture of somebody who's given out. So she doesn't look bad right now, but we're going to put her in EIA. She's going to take a nap. And her CO2 is going to go 50, 60, 70. And what happens to your pH? Your pH goes down and you're right back to that flatline stuff. Yeah, exactly. So this is where we're saving lives.
Walking down the EIA hall and they're.
Yep, absolutely. And then when we take this to M&M, Godwin stands up there and he says, if y'all had done the numbers like this right here, you'd obviously recognize this lady was about to crash. I can't believe you put her in the ICU. So this is a perfect example of where we can apply this stuff clinically. You know, you get an extra couple of minutes, you sit down, you crank out those numbers, and you go, wait a minute, something doesn't add up. There's something funny going on. That's when you get your senior residents back over and have them look at it. All right, we got 10 seconds for one quick bonus case. All right, you guys have all seen this. Strong young lady, she's got DKA, but she's, I don't know, she looks like anybody in this room. Just young, strong, athletic person. She's over there in bed 6, and you're thinking, she doesn't look so bad. You get her basic diabetic labs back on her, and it turns out she's got a bicarb of 4. You think, holy smokes, man, it's amazing how these young people can compensate. What she's doing is she's sitting over there breathing really fast. She's blowing her CO2 down, so she's bringing her pH back close to normal, so she's looking pretty comfortable. When you go back and you look at her, you realize that she is sitting there she's breathing pretty deep, but she's a young, strong, healthy person, so we don't really recognize that up front. Always blows my mind how well these people can compensate, but they can't do it forever. So that eventually they start to get tired, and we start giving them meds, and they get upset, and they get kind of nauseated, and they get weak, and they get tired. We eventually wind up intubating these guys. So we take her over to recess, we intubate her, we walk off and give each other high fives for a great intubation. And about 5 minutes later, Cindy starts hollering and says, y'all get back over here, she's coding. What happened to this gal?
Her acid dropped down too low.
Yeah, I think you're going the right direction.
The bicarb went down to them.
How's she compensating? What's she doing to compensate?
Well, she
Oh, we stopped her
Right.
breathing it off,
Right.
so what ended up
Right.
happening is she's not compensating for it.
Absolutely.
Yeah.
She's been sitting over there breathing 40 times a minute, not complaining because she's a young, healthy, strong person who doesn't want to be in the hospital. We intubate her, we stick her on the vent, We give her a rate of 12, 10, something like that. We impair her ability to blow the CO2 down. Her CO2 starts rising. She's got more acid in there. Her pH plummets. And this is why these guys crash.
Uh-huh.
So another perfect example of where a blood gas like this can really help you. You know she's trying to blow her CO2 down hard to get her pH back to normal. And when we put her on a vent, we've got to crank that rate up so we're matching what she was trying to do. Was this helpful at all?
Yeah.
Yes.
All right, thank you guys. I'm sorry that went so long. I hope I'm not putting
No.
people at high risk for
You still
getting
give bicarb
crashed
for
so
patients
much.
like that?
It's usually
Rare,
bicarb
once
drip.
in a while. The only time we do that is when their pH is so low that we think they're crashing right now, and we're going to push bicarb just to bring it up artificially for that 5 minutes
Oh,
while we
only last
figure
5
out
minutes?
what else it is we can do to fix them. So sometimes we still do, but it's always just in desperate situations. Thank you guys. I appreciate the chance to come.
Thank you.
you.
I don't know what the food is. I came here for the food.
Big man. I'll bring it right back.
No, I
Make
heard
sure
of a
you
good
get a,
speaker you were, so
what do
that's
we
why I
need to do
came.
with
Sorry
evaluation
about
too.
that.
That's just the agenda.
That's okay, that's the agenda.